రంగరాయ వైద్య కళాశాల వైద్య విద్య వ్యవస్థాపకులారా, వైద్య విద్య అధ్యాపకులారా, వందనం వందనం అభివందనం. 60 వసంతాల యౌవని వైద్య విద్యా ప్రదాయని, వైద్యులుగా తీర్చిదిద్దు వైద్య విద్యల ఖని, అవనిలోన పేరెన్నికగని, మా రంగరాయ వైద్య కళాశాల, మా రంగరాయ వైద్య కళాశాల, వందనం వందనం అభివందనం.
Usually we call gentlemen and ladies and gentlemen antagara. So I think there is only one man. So gentle woman and one man. Good morning everybody. Very happy to see that it's an active CME second round is being conducted in Rangaraya Medical College. Yeah, with full colors. So all with GR colors are seen. Women itself are beautiful, and the department of OBG has become more beautiful with 5 professors occupying all the professors' posts, and they are only conducting the CME. I am extremely happy that it is actively being done. So once I have taken charge as Vice Chancellor, the first thing which we did was revival of the CME for the postgraduates. The first round has been completed, and I think this is the second round which you have been starting and then continuing this continuous medical education. It's 6 years back, this continuous medical education for postgraduates was done by Dr. I.V. Rao Garu when he was the Vice Chancellor, who was very, he is the man behind this hall, Dr. I.V. Rao, and due to so many reasons it was discontinued and we have started. So I'm happy that the placenta has been taken as a topic for you, the unknown. Of course, as surgeons, we use the placenta in different aspects also. So for the burns to be treated, for the non-healing ulcers to be treated, and of course, so a lot of research can be done with the placenta. And I'm happy Dr. Lavanya was mentioning one of your names should be written in the USA to know the etiology of the preeclampsia and eclampsia. I wish you should work as the university head. We are concentrating. We are very happy. Every college is doing very well in their clinics. Clinics in the sense the patient care. But we are very much lacking in the research and publications. The faculty, whichever you have done the publications, are for your promotions. For two for the assistant to be associated, for to be associate professor, and another 2 for the associate to professor. Recently, 2 days back, I was the chairman for the selection of the AIMS recruitment. Assistant professors, associate professors and professors were selected and I was the chairman for that. And I was surprised to see their academic performance, those who have been recruited to the director AIMS Mangalagiri. And whatever, of course the chairman, there are few more members. Their concentration, their standards to take into the AIMS is entirely different. And I understood where we are standing in the state medical colleges. So, few of the things I learned soon after the interviews are over, I told the director there, I have learned lot of things which must be implemented in our medical colleges. Our standards of research, maybe I may not tell zero, but we are at a very lowest step. So we have to do research. In addition to that, we have to do publications also. For publications, you don't need to do much work. Whatever you are working, you have to document it and then take a guidance and then publish it. So, but research methodologies, we are planning from the university to start classes for the faculty how to do research. This year itself, or last year itself, we have started research for the undergraduates. So 500 students were given 10,000 rupees for research purpose for undergraduates, 2 lakhs rupees for the faculty, and for PGs also we have sponsored some amounts. So from our side we are doing, but from the faculty side, of course this year 800 students have applied for the undergraduate research activity. We are happy, but from the faculty side, there was no single proposal from the faculty from 17 medical colleges of the government hospitals. So you need to concentrate on that. It's not only you just take care of the patients. Unless you do publications and research, you are nowhere. You are nowhere in the global field. Not only global, at least to compare with the Central Institute, we are very, very far away. So for that, I request all the faculty to concentrate on the research methodologies from the university. Definitely, we will be giving you guidance and then see that the research activities are started. And one more, whether the students likes it or not, we want to make the CME attendance for the postgraduates compulsory. If they do not attend, maybe 3 times a year we are conducting, and all the postgraduates, whoever is appearing for the exam, unless they have 80% attendance, the examinations they will not be allowed. So I just want to make it very clear, and I think that few of the postgraduates from other colleges have not come. I will give tomorrow itself a memo to them. It is, we are spending a lot of money for all these CMEs, and if they are not utilizing that, it is of no use. And I think unless we make restrictions, I think it may not work out, and maybe we will make with consultation with professors only, we'll make a decision. Unless they get 80% attendance by the time they are appearing for the examination during that tenure. A fellow who is there in second year now, in his time, if there are 6 CMEs, he has to attend minimum 4. So unless they attend, then no recommendations will work. We are very strict on that, and if your HOD writes that he has attended only 4 or less than 3, mercilessly we will not allow them for the examination. Please convey this to your postgraduate colleagues and friends of different colleges also, and later if you cry, and of course it's a simple weapon for all the students, they come and cry. So every day at least 2-3 students will come and cry. So cry will not help you in any way. But I have seen personally in my 30 years of teaching, but once they come to the officials, they start crying. Crying is the one which doesn't give any effect. So please tell your friends that unless they attend, they will not be allowed for the examination. Of course, today wonderful activity is being done, and I am extremely happy that this CME will be a very successful one, and all the students as well as the faculty gets benefited with the knowledge which is being shared today. Thank you, and I don't think this inaugural function should be further prolonged, and let us, I wish this program starts immediately. Thank you.
Good morning, everyone. And on behalf of the Department of Obstetrics and Gynecology, I welcome you all. Of course, most of you are from the Nagaraya Medical College, except when you are too. Anyway, we are welcoming us. So today my topic is placenta. I welcome Dr. Karan Kumari, who came all the way from USA. And placenta, the window of maternal vascular health. So why it is called a window of maternal vascular health? Usually we evaluate the placenta for the fetal health. But the emerging evidence says that the lesions are the maternal vascular malformations which are present during the delivery or during the reproductive period. What are the changes that occur in the vasculature of the placenta can determine the later risk of cardiovascular risk of the women in the later life. That means there is an evidence for you in hand during the reproductive life of the women itself to determine the risk of cardiovascular system or the cardiovascular life risk in the later life. This is what I am going to project. Though the evidence is little, the tests are going to happen and there is a lot of research going on in this aspect. So why we need to know? Cardiovascular disease in women is of major health concern. We all know that the cardiovascular disease acts differently in both the men and also the women. And there is racial predominance, and this racial predominance is stubborn. Cardiovascular risk is more in the African women when compared to that of the white women. And regarding the male versus female incidence, though there is a decline in the cardiovascular diseases altogether in the population, the decline in the female population is at a slower pace when compared to the decline in the male population. Women with a history of preeclampsia do have an increased risk for early development of the cardiovascular disease. The women who give birth to preterm birth and also fetal growth retardation have a 2 to 8-fold increased cardiovascular risk in their later life. And the aberrant changes in the placental vasculature due to the oxidative damage or hypoxia. In all preeclampsia, there will be less oxygenation, and this gives rise to very aberrant changes in the placental vasculature due to the oxidative damage or hypoxia. And the resulting lesions, you call it as a maternal vascular malformations. And these embryos act as a key to understand the early development of cardiovascular disease. So to know whether this women develops the cardiovascular disease in the later life, we have to know what are the maternal vascular malformations and how they occur and why they are occurring in women. So what is MVM or the maternal vascular malformation? So for the placenta, which is a transient organ, which is haemochorial, to go according to the normal pace, it has to adjust itself, and the nutrition and oxygen transport of the placenta depends upon its adaptations to the growing fetus or through the pregnancy. And for this to carry on in a good way, a remodeling of the vascular tree through the residual and the endomyometrial segments of the spiral arteries is necessary. This you all know pretty well as you are reading, as you are going through the preeclampsia chapter. And the extravillous thromboblast, they separate from the maternal interface and they enter into the maternal tissues and cause the remodeling of the spiral arteries. The functions of the extravillous thromboblast are arterial structure and promotes the attachment to the placenta to the uterus and fostering transfer of elemental glandular secretions from mother to placenta. Out of all these, the important function is altering structure and flow pattern of the maternal spiral arteries. The oxygen requirement, how it varies all through the gestational. So oxygen requirement and tolerance vary throughout the gestation. The vascular smooth muscle constricts in response to the neurogenic and hormonal symptoms, and this endovascular trophoblasts initiate the remodeling of the spiral artery, and during this process, the uterine ankylosis mediates all this process. And when the smooth muscle is absent due to the extravascular trophoblastic invasion, the spiral artery is no longer under the control of both the fetus and also the mother. So the spiral artery transforms into a big latrine, which is a flow resistance conduit, and this can supply the blood supply will be in a good way. And the mouth of the remodeled artery is 5 to 10 times the diameter of the unattended spiral artery. So you know the difference, and this picture I think everyone knows very well. So you can compare the diameter of the mouth of the spiral artery in remodeled and the non-modeled spiral artery. So what happens to the oxygen requirement early in the gestation? The developing embryo is susceptible to oxidative damage. So to protect the embryo from this oxidative damage, these extravascular trophoblasts, they separate from the trophoblastic layer and forms plugs and obstructs the spiral arteries. So what is the effect of this obstruction of the spiral arteries? The plasma containing nutrients and the dissolved oxygen enter into the intravenous space, but it won't allow the RBC to go through, so that the oxygen supply to that is decreased. So what is the effect? The oxygen concentration in the remodeled placenta in the first trimester is less than 20 millimeters of mercury, while surrounding maternal testicular oxygen concentration is 50 to 70 millimeters of mercury. And after 12 weeks, this extravascular trophoblast degenerates or dissolves, and the oxygen concentration increases to 40 to 50 millimeters of mercury, which is necessary for the embryo at that stage of development. So the remodeling, how it happens? The remodeling, as you know, it occurs through 2 waves, and through the first and the second trimester, the vesicle and the mitral segments. And in the second trimester, this remodeling eliminates the smooth muscle through 2 thickest vesicula, and in the 1/3 of the mitral. The remodeling is not uniform. You can see in the down picture, the remodeling is not uniform. It is absent in the periphery while compared to the central part. So the spiral arteries which are present in the extraplacental membranes, there will not be any remodeling, whereas the remodeling occurs only in the central part of the placenta. So the resulting damage pattern, this causes, that is, the extraplacental vessels which are present beyond the central part of the placenta are susceptible for the oxidative damage, and this the result of this damage pattern comprises of the maternal vascular malperfusions. Types of maternal vascular malperfusions. There are 2 types of the vascular malperfusions. One is the decidual vasculopathy, and the resulting changes which occurs from this decidual vasculopathy is called the maternal vascular malperfusions. So what is this decidual vasculopathy? This directly involves the maternal vascular supply. They develop early in the gestation. The resulting changes will produce the maternal vascular malperfusions. According to the Brosens, the disorders of deep presentations are more common in each of the great obstetric syndromes. So for every obstetric syndrome that comprises and that causes the morbidity of the female, it is the placenta that is the culprit. So coming to the decidual vasculopathy, there are 4 manifestations in the decidual vasculopathy. The first and foremost and the most important thing is the absent or incomplete remodeling of the spiral artery. Second is mural hypertrophy. Third is fibroid necrosis, and the last subtype is endosis. I deal with one by one. This is the remodeled spiral artery. You know it pretty well how the remodeling will be because of the extravascular trophoblastic invasion and loss of smooth muscle. So here in the picture, you can see the loss of vascular smooth muscle. So smooth muscle is absent and the entire thing is converted into low resistance conduit. There will be fibroid deposition along the walls. This red thing is the fibroid deposition, and there will be extravillous trophoblasts within the fibroid. So this is about the remodeled spiral artery. The second is the mural hypertrophy. uniform and it will not be that much in the extraplacental vessels when compared to the central part of the placenta. So what happens is thickening of the smooth muscle wall of the spiral artery is present at some places. This is common in the spiral artery of the extraplacental membranes and it can occur in the absence. Usually, neural hypertrophy, if you go into the medicine part of the vascular diseases, you'll see the neural hypertrophy only in presence of the chronic hypertension. But with placenta is the only condition where you can see the neural hypertrophy as a pathological change in the absence of chronic hypertension. So here you can see four vessels. This is one vessel, this is another vessel, this is another, this is another. So this is what we call it as a neural hypertrophy, the hypertrophy of the muscular layer. Okay, the lumen of the vessel is so small in these vessels. This is the subtype of, or the second type of the residual vasculopathy. The third one is the fibrinoid necrosis. The normal vessel wall is replaced by a prominent layer of waxy deep fat material. This represents the remnant degenerated debris of the vascular smooth. There is a difference between the normal fibrinoid and the fibrinoid necrosis. Fibrinoid devolution is normal, but the fibrinoid necrosis is pathological. So how do you differentiate between the normal fibroid and the fibrinoid necrosis is the normal fibroid is light pink to red in color and is associated with the extravillous trophoblast and consists of the extracellular matrix. So here you can see this is the wall is replaced by the fibrinoid material. We are seeing this. Usually if you go into the vascular vein, there will be a smooth muscle. Here the smooth muscle is replaced by the fibrinoid necrosis. The last subtype is the atherosis. The features are similar to large vessel atherosclerosis. Certain anthropopaths are present within the walls of the spiral artery and they are adjacent to the fibrinoid necrosis or fibrinoid. Atherosis and the fibrinoid necrosis. Atherosis and fibrinoid necrosis commonly co-occur. I think the tubes have been reordered. Okay. So atherosis and the fibrinoid necrosis commonly co-occur. Here you can see the arrows are pointing towards the layer of the macrophages. These are the layers of the macrophages that form a layer, and this is what you call as atherosis. The atherosis is just like the atherotic changes what occurs in all the hypertensive disorders in the rest of the vascular tree. So coming to the atherosis, the incidence of the atherosis in preeclampsia is around 10.2%. Intrauterine fetal death is around 9%. Fetal growth rate restriction is 1.7%. Spontaneous preterm labor is 1.2%. Uncomplicated pregnancy, you see only in 0.4% of the cases the atherotic changes are present. And presence of atherosis in a placenta results in 6-fold higher incidence of the maternal vascular malformations. So also, as you assume, the atherosis is the culprit for the hypertensive vascular diseases elsewhere in all the human beings. This atherosis, if you find in the reproductive life, there is a maximum increased risk of the cardiovascular risk in the later life of the women. Yes, the staff and colleagues and the first wants to propose a hypothesis saying that the maternal pathology in a transient organ requiring only few months of gestation to form and may provide an accelerated life course model of vessel susceptibility to metabolic and vascular impairments later in life in the face of challenges like aging and weight gain. So, though the life of the placenta is only 9 months, it is causing a major havoc which is leading to the vascular disease in the later life of the women. So, what are endocrine lesions and the maternal vascular malperfusion lesions? The lesions that arise as a consequence of the hypoxia or the ischemic injury caused by the residual vasculopathy, you call it as a maternal vascular malperfusions. So these malperfusions are included under one criteria, that is the Amsterdam criteria, which constitutes the intravillous thrombosis, which leads to the small placenta, villus infarction, tetraplacental hemorrhage, accelerated villus maturation, and villus hypoplasia. So if you look at this villus infarction, this is most easily recognized lesion. Usually 30 to 60 spiral arteries supply the placenta, and when there is an infarction in the particular spiral vessel or occlusion of the spiral artery, what happens is there will be infarction of the villi, which is overlying the opening of the spiral artery. So if you can see, this is the spiral artery, and if there is an obstruction to this spiral artery, the mouth of the spiral artery, the villi is supplying this will undergo a infarction. And this infarction occurs, extends both horizontally and also vertically till the extent that there is a supply from the surrounding and the peripheral of the subjacent adjacent villi. There will be mixing of blood. So the blood from this villi and blood from this villi will be mixed at this point. So this infarction extends both horizontally and also vertically till the place where there will be adjacent mixing of the blood from the adjacent villi. And that is the reason why when you are doing an ultrasound for the hematomas, the subchorial hematomas in the first trimester, these hematomas will be having a crescent shape with a wedge shape and a broad base and a wedge shaped manner, or it may be in the pyramidal-like manner. So this is the reason for that. The gradient of the hypoxic damage extends from the infarcted tissue to the nearby surviving villi. So the second one is the accelerated villus menstruation. I think all of you have seen the movie Part, where there will be an accelerated menstruation of Amitabh. Okay, so likewise there will be an accelerated villus menstruation. So how will be the villi in the first trimester? The villi are large, with abundant loose stroma and centrally placed vessels with two layers of the trophoblast, the syncytial trophoblast and the cytotrophoblast. Whereas with increased gestation age, the villi becomes smaller with dense stroma and the villus vessels have gone into a periphery and dilated into sinusoids. The trophoblast is thin out and there will be aggregation of the syncytial trophoblast that we call it as a syncytial knot. And these changes of accelerated villus menstruation will be recognized in the preterm placenta, and the changes in the term placenta are very difficult to diagnose because they are very subtle. And this is the most frequent embryo lesion, and the villi undergo the unidirectional changes throughout the pregnancy. This is the picture of villus menstruation at 27 weeks, and this is normal. Yes, keep this picture just before your eyes so that you can compare the accelerated villus menstruation at 27 weeks with the small villi and the high percentage of the syncytial glands. You can see more of the violet stain here than compared to that of this picture. Okay. So these are the violet ones which are surrounding the inner periphery of the syncytial glands. Next is the distal villus hypoplasia. So you can say the villi are partly away and there will be a hypoplasia. That means they occur after the prolonged fetal hypoxia and are characterized by the non-branching angiogenesis of the villi. The villi are long and thin, intervillus space is open with widely scattered villi. The syncytial knots are increased, associated. This is the stage where it is associated with the absent or reversed anti-arterial flow in the umbilical artery, and there is an increased PI in umbilical artery and fetal growth retardation. Coming to the syncytial knots, the syncytium acts as the endometrium of the villi, and this is the primary zone of contact with maternal blood. Syncytial knot is nothing but a clustering of 5 or more of the nuclei of the syncytial trophoblast to form a round bulge above the villus surface, and this denotes the fetal maturity. So the number of syncytial knots denotes the fetal maturity. This is how the syncytial knots are. The peripheral deposition of this violet material are the syncytial knots. They come onto the villus surface. There is another thing that we call it as a syncytial sprouts. Sprouts is nothing but an extension of the projection from the surface. This is the outgrowth from the syncytium arising within proliferation of the villus tree, observed in the early gestation, and in later gestation they appear more in the hypoxic regions of the lobules. So these syncytial knots, the changes in the syncytial knots and this syncytium are grouped under the Kenny-Parker changes, and this denotes the placental well-being, and this is rarely seen in normal pregnancy before 20 weeks of gestation. So coming to the percentage of syncytial knots, around 20 to 25 weeks it is around 5.2%, 9.1% around 28 weeks, 25 weeks, and 22.5% at 36 weeks, and at term it is around 28%. So if you go and calculate this, you can calculate even the gestation age of the fetus. Then coming to the other MVM lesions, okay, you can compare the both. This is the normal villus menstruation and this is an accelerated villus menstruation. The Document చేస్తాం సార్. Abnormalities will write.
నార్మల్ అప్పుడు కూడా ఏ టైప్ రాయడం
రాసేస్తాము. Abnormalities will maintain for the car. Will write for both the umbilical cord and the placenta. And all still a small placenta will have a atrial drain. ఇక్కడ కాదు.
స్పెషల్ గెస్ట్
Guest of
గెస్ట్
Sir, out of our